Let's talk about short-lasting unilateral neuralgiform headache attacks. These are called SUNCT and SUNA. So, SUNCT is when you have these short-lasting unilateral neuralgiform headache attacks with conjunctival injection and tearing. Both are required. If you have any other unilateral autonomic symptoms, it's called SUNA. And these are both trigeminal autonomic cephalalgias. They present more commonly in women, roughly 2 to 1 prevalence, and the average age of presentation is in the 40s. For clinical features, it requires at least 20 attacks of moderate to severe unilateral stabbing or sawtooth pain in the trigeminal distribution. V1 or V2 are most common, and V3 is a little rarer. So this is in contrast to trigeminal neuralgia. The attacks last for anywhere from 1 second to 10 minutes and requires a ipsilateral autonomic symptom. This can include conjunctival injection, lacrimation, nasal congestion, a runny nose, eyelid edema, sweating, meiosis, or ptosis. And again, if conjunctival injection and lacrimation are present, then SUNCT is diagnosed, and otherwise any other combination of autonomic symptoms is called SUNA. So classically, there is no refractory period between pain episodes, unlike trigeminal neuralgia, so this is one thing that can help you distinguish between the two diagnoses. The neurologic exam is typically normal, although sensory abnormalities on the face can be seen. SUNCT and SUNA typically lack response to endomethacin. Up to 225 milligrams daily is sometimes tried to differentiate between this and paroxysmal hemicrania. It's also less responsive to oxygen compared to cluster headache. For evaluation, MRI brain is done to rule out intracranial structural lesions. The most common lesions can be pituitary and posterior fossa lesions. For treatment, acute attacks can be alleviated with IV lidocaine, and note that this will require EKG and monitoring of vitals during treatment, as IV lidocaine can cause arrhythmias. For preventative therapy, lamotrigine can be considered to be first line, but oxcarbazepine and topiramate can also be used. Greater occipital nerve block or stimulation may help if first-line therapies fail. For prognosis, SUNCT and SUNA both can persist and become a lifelong disorder, but can also resolve over years. Because it is a rarer disorder, there is not much data on prognosis.